Great. Well, welcome everyone to our October 2023 version. Our theme is collaborating to reduce work and control workplace exposures. And I'm so happy to have you. I think it's our 8th annual, starting off today with evidence for exposures of concern. And I'm coming to you today, so I'm going to hand over as quickly as possible because there's some background noise at the Firefighters Occupational Exposure Reduction Workshop with the International Association of Firefighters in Health Canada. So again, on our theme of preventing occupational illness and disease and learning a lot from these folks. So I want to welcome you and ask you to join. Oh, thanks. It's popping up on my screen. I'll stop sharing. Yes, and next week we hope to follow along. And just I'll scroll down our screen here, so if someone can put the registration in the chat. Today we have John, Victoria, Arrandale, and Krista speaking. And next week we're going to launch the silica control tool. We felt that was a good full circle moment since we presented on this silica control tool about 3 years back with Hugh Davies and Melanie Gormaning. And so we're getting a full circle moment, bringing it to Ontario, and then talking about what all of our system partners are doing with the Occupational Illness Prevention Steering Committee. And then November 10th, we have the OCC Landscape Review. And the 17th, we have Occupational Exposures and Diseases Making the Link. And then finally, we will have a panel on airborne hazard management programs, reducing exposures in mining. So welcome everyone. I'm going to hand you over to Krista to moderate the session and try to stop sharing here if I can.
Okay, I'm going to start with a land acknowledgement for our October series based on where I am and guided by OHCOW's values. First, when we say Indigenous peoples, we're referring to the people of social and cultural groups that share collective ancestral ties to the lands of a region. Many Indigenous peoples from what we call North America, many Indigenous call Turtle Island. So I assume most people are watching from Ontario, but for those further abroad, most are from Turtle Island. While I'm speaking, I invite you to look up whose lands you're on, which you can do by visiting www.whose.land. So www.whose.land. Today, I'm in Harrowsmith, where the Anishinaabe, specifically the Algonquins, have lived since time immemorial. The Anishinaabe are made up of multiple nations in addition to the Algonquins. They speak Anishinaabe-Moan, sometimes called Ojibwe. Traditionally, Algonquin people use birch for many purposes, including in their wigwam, their homes, canoes, and for paper. And in my family, my grandparents were actually really inspired by this when I was a kid, and they used the peeling birch bark that was already peeling off birch trees they had to send letters to my brothers and I when we were kids. So feel very connected to the culture, as connected as I can be to someone else's culture in that way. I also will work and spend time quite a bit in Kingston, which is home to Anishinaabe, as well as the Haudenosaunee, specifically the Mohawk Nation. Mohawks are the easternmost nation within Iroquois Six Nation Confederacy. They traditionally lived in longhouses, which continue to be culturally important today. I want to talk a little bit about the undertaking to preserve the Mohawk language called Kenyan-Keha. Just a few years ago, this language was on the verge of losing all native speakers. And language is really important to culture. Language and culture are very tied together. So it's really important that they are doing this initiative. Some words that we use every day come very indirectly from Kenyan-Keha. So Ontario comes from Kani-Ontario. I do not know if I'm pronouncing it quite right. I tried listening to it, but there is that connection there. And another word within their language, Kanata, became Canada. In addition to the land acknowledgement, I wanted to acknowledge the impact of occupational health on the Indigenous populations. So a review published last year, it was a review of 31 studies published by Dr. Durand Moreau and colleagues, noted that Indigenous workers are experiencing intersectional occupational issues. Due to a variety of socioeconomic factors and systemic racism, Indigenous peoples are less likely to have access to formal and informal training and education. They are also underrepresented in professional Professional, scientific, and technical services. This review identified Indigenous peoples are less likely to be hired even if they are qualified. And if they are hired, they're more likely to face workplace discrimination, largely due to racism. Indigenous peoples are also more likely to have cumulative health issues from both occupational and environmental exposures from industries located close to where they live, compounding their exposure risks. The only Ontario-centric study I found was a qualitative study published last year by Dr. Lightfoot and colleagues, including Dr. Arrandale, who's speaking later today. This study identified workers in Ontario workers' compensation system may be in need of Indigenous cultural competency and awareness training. A 2014 study by Dr. Jin and colleagues in BC identified that Indigenous people are more likely to have occupational injuries and diseases than an average person in the BC workers' compensation system. Unfortunately, we really don't know if that's the case in Ontario. I couldn't find any data with this focus, but it's reasonable to hypothesize it's a possibility. All that said, OHCOW recognizes these disparities exist in the workplace settings and in our society, and we wish to do what we can to promote occupational health in all workers, including Indigenous workers. So with that said, I'm going to move on to the first speaker, John Oudyk. John, if you want to start getting ready, I'll introduce you. Since 1989, John has worked as an occupational hygienist with the Hamilton Clinic of OCCOW. Prior to working at the clinics, he spent about 10 years working in health, safety, and environment for a manufacturing company with 3 foundries and a couple of factories. His educational background includes a Bachelor of Applied Science in Chemical Engineering from the University of Waterloo in 1983, and a Master's of Science from the McMaster University Health Research Methods Program in 2005. He had an appointment as an assistant professor part-time in the McMaster University Department of Health Research Methods from 2007 to 2019. He is certified both with the Canadian Registration Board for Occupational Hygienists and the American Board of Industrial Hygiene. One of his pet projects has always been trying to assess exposures using questions posed to workers. So I will turn that over to John.
Thank you, Krista, and welcome everyone. Thanks for dropping in. This is a description of some of the results of a survey that we did with a company called EKOS, and we put together something to get an idea what workers are exposed to every day. Now, we have recently heard about a new occupational exposure registry, which I believe is more quantitative, collecting data that has been collected in workplaces, measuring worker exposures. In the EU, there's a project called ESSENER, which stands for European Survey of Enterprises on New and Emerging Risks. And this is a survey that's sent out to employers asking about exposure to different factors. And this was a bit of an inspiration for us. And you'll notice that some of the questions we have are actually find their way back to this survey. So we did a similar survey in 2019, and we consulted with some partners, including Victoria, who's also speaking today, and also people in the Institute for Work and Health. And we put it together based on the IWH's vulnerability survey. We took certain questions from them. We patterned new questions based on their question structure. We also included questions about sun exposure, wet work, indoor air quality, workstation comfort. We are also interested in exposures that might cause allergic reactions and the use of medication to alleviate workplace symptoms. In 2019, we included the IWH Organizational Performance Metric, or OPM. And we also had a number of questions about health and safety and workplace environment concerns that we've been using in our own stress assess tool. We collected about 1,700, almost 1,800 responses from 4 provinces, Ontario, Quebec, Alberta, and British Columbia. We took 1,000 from Ontario and 250 from each of the other provinces. And these were weighted according to age, gender, and region to be representative of the Canadian labor force. When we updated this survey, we made a couple changes. We had basically the same thing, but we left out the OPM questions and added questions about occupational health and safety awareness and participation from the IWH's vulnerability survey. This survey was done in February and March of this year, and we had almost 1,800 responses. Again, a similar breakdown from the 4 provinces, and again, weighted according to age, gender, and region. This is the breakdown of the economic sectors. These are corrected ones. People are notorious for not responding to economic sector very well. So we have a bit of a strategy where we ask people, what do they do first? And then ask, what does your organization fit under any of these categories? And that got a bit of better response than the other way around, which we did the first year. But you can see education, services, healthcare, and social assistance, and public administration were the predominant ones, being over 1/3 of the respondents just from those sectors. In the vulnerability scale, we used some hazard exposure questions, and as I said before, the awareness and participation questions. And here are the results. We changed the scale slightly from the IWH, and the numbers are fairly similar. I've ordered them in the most frequent exposures, which was repetitive movements, and the least common were doing work that you're not familiar with. And we'll go into each one of these separately. So one of the questions was lifting, carrying, or pushing items heavier than 20 kilograms at least 10 times a day. And here are the different sectors ordered by the most frequent. So transportation and warehousing, 37% of the respondents. I put the numbers in along the side there because, as you can imagine, a survey of 1,700 people, when you break it down into 18 categories, some of the categories get pretty small. You see that agriculture, forestry, fishing, and hunting, all 4 of these combined are only 24 respondents. And so you need to take these numbers with a grain of salt. So accommodation, food services, construction, and mining and quarrying, oil, gas extraction were the top 4. And then asking questions about repetitive movements with your hand or wrist for at least 3 hours a day. Again, accommodation and food services is up there, but also healthcare, construction, and retail trade, and transportation and warehousing were the top 5. Unfamiliar tasks, agriculture, forestry, fishing, and hunting was far above the others, 17% compared to 9 to 10% for manufacturing, arts, and utilities. Interacting with hazardous substances, such as chemicals, flammable liquids, and gases. Mining, quarrying, and oil and gas extraction were half the respondents had exposure at least a few times per week or more often. Almost 1/3 for utilities, accommodation, food services, and manufacturing. Bent, twisted, or awkward postures. Here again, healthcare came out on top of this one, followed closely by mining etc., and transportation and construction. Working at heights, mining and construction, which is what we would expect. We're far beyond any other economic sector. Transportation and agriculture and manufacturing were another set, about 10 to 15 points behind the other. Noise. We define noise as having to raise your voice when talking to people less than 1 meter away. It's notorious that if you ask the question straight out, are you exposed to noise, that you get very poor answers. And so this focuses the question a bit more to interruption of communication. And mining and quarrying, again, much above all the others, followed by manufacturing, construction, transportation, and warehousing, also 30% or more. Standing work. Standing for more than 2 hours in a row. Accommodation and food services, 85%, which is huge. Again, be careful. There's only 40 people responding. Retail trade, again, which makes sense. Manufacturing, education, construction, and transportation and warehousing, also over 40%. Solvent exposure. Take note that mask that the person is wearing will not stop solvents. It's for dust, if it does that well. In your job, how often do you perform the following tasks? Breathing in gases, vapors, or solvents? And 8.4%, at least a few times per week, most days or every day. And this is down from 2019, which was 10%. And the economic sectors which were most exposed were mining, quarrying, and gas extraction, oil, and manufacturing and other services, which is interesting. We also asked people to describe the type of gases, vapors, or solvents that they were exposed to. And it looks like cleaning agents were clearly the most commonly represented, although exhaust, paint, fumes, solvents, diesel, chemicals are also mentioned. It was about a quarter of people responded to that. We also asked a similar question about smoke, fumes, powder, or dust. And here we have 11.5%, at least a few times per week being exposed, quite a bit down from 2019 at 16.6%. Mining, quarrying, oil and gas extraction, manufacturing, construction, transportation and warehousing, accommodation and food services were all fairly high there. And again, we asked what type of smoke, fumes, powder, or dust. And when you ask people, are you exposed to dust? They say, yes, I'm exposed to dust. Smoke, exhaust, welding, diesel. And this highlights some of the problems with asking people to describe their exposures. The words they use are not necessarily the same words that occupational hygienists or health and safety people would use. And so it's very difficult to, in a generic survey, zero in without some overlap with the solvent question. Vehicle exhaust, about 10%, at least a few times per day, exposed to vehicle exhaust, down from 13% in 2019. Manufacturing, clearly much higher than any of the other ones. The people who put together the economic sectors and define what they are have a really weird one called administrative and support and waste management and remediation services, which is a real mixed bag of different, and plus we have very few people in it, only 36, but they were next, followed by mining sector again. Diesel exhaust, getting more specific, about 8%, roughly the same as 2019, which was 9%. Again, manufacturing and the administrative and support and waste management and mining and transportation, obviously. If you are exposed to diesel exhaust, which of the following best describe your exposure? And 4.2 were regularly exposed to a significant level or constantly exposed to a significant level, down a bit from 6.5% in 2019. And those who were regularly or constantly exposed were again, this odd group, waste management, probably, more or less, manufacturing. IT was in here, which is curious, and professional and technical services. Asbestos in buildings. We ask which of the following best describes your experience with asbestos in the building where you most often work. And 1.4% has said that I have at least disturbed asbestos in the building, or I sometimes or I regularly disturb asbestos. In 2019, we gave the option, only a single option. They could only choose one. We changed that to choosing as more than one option. And so the 1.4% is the same, but that may be because of people picking other options, although the total response was only 5% more than all of them. However, 43% did not know whether or not their building contained asbestos, which I think is an important thing to know when you're in a building. Disturbed asbestos at least once or more often. Obviously, construction, manufacturing, utilities makes a lot of sense. Transportation and warehousing, especially breaks that might have still have asbestos in them. Mining and quarrying were the top 5. Engineered nanoparticles. Again, a similar question. Work near a source of engineered nanoparticles, or occasionally work directly with, or regularly work directly with, and it was 1.3%, down slightly from 2019. However, when you combined, I don't know if engineered nanoparticles are present in my workplace, or I don't even know what they are. The combined there was 93%. That was up slightly from 2019. That's not heading in a good direction. Manufacturing, obviously, was the most economic sector reporting the most exposure. IT, interestingly, accommodation and food services. That one was a bit surprising, in agriculture, forestry, and transportation. Now, we put all these questions together and put together this heat map, and you can see that along the top here are the exposures, and the most common exposure was repetitive movements with your hands and wrist, and the least often was working with nanoparticles. And then we ordered the economic sectors by the ones that had the most frequent in all the categories added up together. And mining, construction, transportation, and manufacturing were the top ones here. Accommodation and food services were very high in the first two, but quite low in the last one. So depending on how you slice it, these could be higher, especially when you're looking at ergonomic hazards. A retail trade, similarly. And if you're looking for an economic sector with the least exposures, it looks like finance, insurance, real estate, renting, and leasing had the lowest exposure. Next lowest was IT, and then professional, scientific, and technical services. Sun safety. During the months beginning May until the end of September, between the hours of 10 a.m. and 4 p.m., how many hours do you work outdoors in direct sunlight if the sun is shining? And we have almost 9% who work 4 to 8 hours outdoors in the sun, and 71% that are not exposed. And if you do work outdoors in the sun during those times, how often do you use sun protection, sunscreen, or clothing that covers your skin? And 37.8%, which both very similar to before the pandemic, seldom or rarely or never wear sunscreen. Light at night. At your work, are you exposed to artificial light at night, like during night shifts? 17% frequently or always, versus 20% before the pandemic. And wet work. On a typical day, how many times do you wash your hands with water, including when using the bathroom? And the peak, there were 2 peaks, one at 5 times per day, where up to 20%, and another one at 10 times per day. And on a typical day at work, excluding time spent hand washing, how long do you have your hands immersed in or covered by any liquid, including water? 1 hour a day was 16%, and then we have about 5% more than 1 hour a day. On a typical day, how long do you wear gloves that prevent your hands from getting wet? And here again, we have 1 hour a day, about 7%, but we have almost twice or more than twice that much having 2 hours a day or more. Seated work. On a typical day, how much time do you spend in a seated position? And just about 60% was 4 to 8 hours, and 4.5% more than 8 hours, both of which were higher than before the pandemic. And I think the working at home probably has an influence on that. And how would you rate the comfort of your workstation where you work most frequently? About 10% were annoyed or felt it was very uncomfortable, which was down a percentage point from 2019. Thermal comfort, and we used the Fanger 7-point scale, which is similar to the ASHRAE scale. And this is defined as the comfort zone. You're allowed to be slightly cool or slightly warm, but shouldn't be warm or hot or cool or cold. And we had 74% who were in that middle section, slightly cool to slightly warm, quite close to the ASHRAE target of trying to please at least 80% of the people with the thermal comfort in a building. Distracting or annoying noise. Typically, how frequently are you distracted / annoyed by noise in your workplace? 20% were frequently or always, down slightly again, which makes sense if people are working more from home in 2023 than 2019. Although myself working from home, and when the grandchildren are here, I'm sometimes slightly distracted or annoyed. Distracting or annoying odors. Again, similar type of question, 6.7%, down a few percentage points from 2019, which working at home might explain. And if you detect odors at your workstation, what effect do the odors have on you? And 11% said it causes at least discomfort or mild symptoms. A few said significant symptoms, and a very small percentage said it actually causes severe enough symptoms that they occasionally miss work. And again, it's down a few percentage points from 2019. Air quality. How would you rate the air quality in your workplace? Anywhere from terrible to excellent. And the terrible to poor was 7.1%, a little lower than it was in 2019. And do you use medication to alleviate symptoms caused by workplace exposures? This stayed about the same, 7.5%, at least weekly, a couple times a week, or daily. And allergies in the workplace, is there anything at work that causes you to have allergic reactions? And 20% said yes. Has a doctor ever told you that you have asthma? And about 11% currently have asthma. Almost 15% said they had it, but no longer have it. 75% never had it. Workplace infection control programs. These were added, obviously, after the pandemic. Does your employer have an infection control program? And 71% said yes, 12% no, and almost 17% not sure, for a combined of about 29%. If your employer has an infection control program, how would you rate the adequacy of the program? And we had two factors here. You could have an adequate policy, but not adequately implemented. So if you had adequate policy and effectively implemented, that was about half the respondents, but almost 20% said they either had an adequate policy without adequate implementation, or they had an inadequate policy or no policy at all. Do the sickness, absenteeism, sick leave policies at your workplace encourage or discourage sick workers from coming to the workplace? And 15% said they discourage sick workers from staying home. And 62% said they encouraged sick workers to stay at home until they were well. And almost a quarter said it didn't have any effect on the sick workers coming to work or not. In our hazard assess app, we have a list of hazards that we ask people whether or not they're concerned about. And this app has 12 areas that we ask questions about, and we ask whether it's the controls for the or the concern for the hazard is either they think it's well designed, controlled, present but not usually a concern, causes annoyance, and or the worst is interferes with the ability to get the work done. And we've colored these according to top 3 concerns and listed them here. And you can see psychosocial hazards is almost 40% of the respondents, whereas thermal comfort, the next one up, and ergonomics is about 27-28%. And when we look at the difference between the 2019 to the 2023, there's clearly the frequency has gone down for each category, but most often for thermal comfort and ergonomics and air quality, the top 3. And again, this could be an artifact of more people working from home. Although ergonomics usually it's tough to get as good an ergonomically designed workstation at home as it is perhaps in the workplace. And we also put these in a heat map, and we looked at all the concerns for the various hazards, the psychosocial hazards being the most frequent and the radiation concerns being the least frequent. And then we ordered the economic sectors. And it's somewhat similar to the questions directly about being exposed. This is exposure concerns. And mining, manufacturing, utilities, education, and public administration being at the top. Again, finance, insurance, retail, real estate, and leasing at the bottom with IT. Retail trade was actually lower in the concerns than it was in the exposures. How would you rate the psychological health and safety climate in your workplace? This is a question we've used in lots of questionnaires, and so we thought we'd use this to try to compare. And 74% were on the positive end of this scale, whereas before it was 73%. And the negative side was roughly the same, 18%, almost 19% in 2019. So not much change there. The new questions about health and safety rights, the first two questions being, I feel free to voice concerns and suggestions about health and safety, and I know I can stop work if I think something is unsafe and management will not give me a hard time. And the combined there was about 14% and 15% either disagreed or strongly disagreed. Then there were two questions about whether there's an active, effective health and safety worker, health and safety rep in the workplace. And here we have almost just over 20% either strongly or disagreeing or just disagreeing. And I am clear about my health and safety rights and responsibilities with about almost 13% there. So we have more to do in the analysis of this. We need to code the jobs and then break them down into job categories. Also, we have collected some demographics and see what the breakdown is by that. Look for correlation or factor analysis and compare them with other people's exposure data, such as CAREX. Do a bit of comparison between Ontario and the other three provinces. And if anyone has any interests or questions that we might be able to answer from this data, please forward them to us. Thank you very much, and I'd be glad to entertain any comments or questions.
So anyone's welcome to unmute themselves to ask questions or put them in the chat. I'll just make a comment. The health and safety rights proportion or portion of it, that just blew my mind. Not in a good way.
Yeah, hi, John. That was great information. How can this data be used to protect workers' health going forward? What, both from kind of that structural systemic piece and also by kind of individual industry?
Well, some of the questions scream out for a response. For instance, 43% of people not knowing whether they have asbestos in their buildings. Part of the asbestos regulation is to inform the occupants of the building that they have it. And the nanomaterials too. The fact that the ignorance about nanomaterials is actually increasing instead of decreasing is a big concern. So some of those are obvious. Some of the sectors, it looks like certain sectors could use quite a lot of attention. it's such a wide ranging survey about so many different exposures that each exposure question on its own, you could either target sectors or investigate further what, for instance, repetitive motions, which was the most common exposure that we asked about. That can be anything from typing on a computer to working on a line and doing the same thing over and over. So some of it needs to be dug down more by sector, and so it should be able to guide people. The other thing I found interesting was what the concerns are. You know, we often assume that people are concerned about chemical exposures and safety hazards and things like that, but yet the top concern by a clear 10 percentage points more than anything else was psychosocial hazards. So again, we can kind of do a reality check and see if what we're focusing our efforts are really aligned with the exposures people are reporting and the exposures people are saying they're concerned about. So it's a starting point, and there's lots to do. You're muted, Steve.
Oh, sorry, I saw I was muted. Can you break down your data by union members versus non-union members?
We did ask the question whether the workplace has unionized members. I didn't show that, but that's one of the demographics that we can work out. In the past, in some of my surveys, what I have found is that sometimes unionized workplaces have more hazards than non-unionized workplaces, and or that people recognize hazards better in unionized workplaces. So sometimes you get surprising results, or results that might not fit with your previous hypothesis, because it's actually a little more complicated than we think a straightforward comparison.
Thanks so much for the work you're doing on this.
Oh, thanks, Steve.
John, I'm just going to read you a question from the chat.
Okay.
Sarah asked, do you have any data yet on medicine use?
We asked the one question whether the people use medications to alleviate their symptoms in the workplace, but that's all that we asked. We didn't ask what kind of medication or anything like that.
Okay. So you'll be presenting that data at another event, I guess. It's okay. You can tell us later. It's okay.
No, I did. There was a slide about whether or not you use medication to.
I'm sorry, because I slipped out to get a quick sip of water and I missed it.
Okay.
Thanks, John. I'll go back to slides. Another question: has the Ministry or Ministry of Labor, Immigration Skills Training Development, or the WSIB expressed interest in a presentation? Maybe there are folks here from there. Just wondering if.
Kimberly asked me to present this to some group. I'm not sure what group that was.
One of the working groups at the ministry, great.
But I did present that.
Good stuff. And another question is, are you planning to publish this like in a scientific journal? I'm just asking because, you know, sometimes people want to know what's the rigor of this study, and if it's published, then sometimes people think that it's more important. So is there a plan?
If somebody wants to help write it, I'd be
Okay.
glad to help out. You know, but that's not really one of my prime objectives of my job. But I thought I would just share the slide you missed.
Oh, thank you. Maybe others missed it too. Because I am interested in, like, the Institute for Work and Health, where I work, is interested in like opioids as a potential opioids use and harms as a potential reaction to symptoms in the workplace as a result of an injury, or as a result of just getting on with work because you're kind of forced to keep working?
Yeah, this question was kind of embedded in the air quality and the allergies. And so I don't think it would necessarily get to that. It
Okay,
would
so
more,
maybe, I don't know if you're going to do more, maybe a question about that, or that could be another survey and we could talk.
Yeah.
Thanks, I'll stop.
Okay. Okay, if there's no other questions, I think my time is up and I'll turn it back over to Krista.
Okay, thank you, John. Yeah, that was really interesting. I was shocked by more than one thing in there. And like I said a minute ago, the health and safety rights just blew my mind. For all the information that's out there and all the good work that a lot of people are doing in all the health and safety systems, there's still more to do. We haven't put ourselves out of work yet. So I'm going to introduce Victoria Arrandale. Victoria Arrandale, PhD, ROH with Dalla Lana School of Public Health. Dr. Arrandale is an assistant professor at the Dalla Lana School of Public Health at the University of Toronto, and she's a registered occupational hygienist. She's active in the provincial health and safety system and sits on the WSIB Scientific Advisory Table on Occupational Disease. Dr. Arrandale's research focuses on the measurement of workplace exposures and the assessment of exposure in occupational epidemiology. Her work has examined exposures in a variety of workplace settings, including mining, construction, nail salons, and electronic waste facilities. So with that, I will turn it over to Dr. Arrandale. Thank you so much for being here.
Thank you. I'm going to share my screen here. Great. So I can't see you anymore, Krista, but if there's a way for you to let me know if you can see the presentation
I can
mode.
see the slides.
Perfect. Yes. Thanks very much. So thanks for inviting me to speak as part of the October seminar series. I'm going to share some results from a recent study that was done with a large group. So I'm the messenger today, but this work was a collaboration between Dr. Lau, Dr. Tarlow, Dr. Holness, Dr. Rajaram, and Annabelle Zhang, who works with me at the Dalla Lana School of Public Health. And really, we've been getting, I think, a lot of folks thinking about silicosis a bit more. And so we've got a bit of a provocative title, but what we're talking about is silica. So silica is a naturally occurring mineral. It's in the Earth's crust, and we often, as hygienists and health and safety folks, talk about silica. What we're talking about is the crystalline form of silica, and its quartz is the most common crystalline form that we find naturally occurring. But there are non-crystalline forms that do occur as well, and we're less concerned about those from a health perspective. As you might expect with crystalline silica being naturally occurring and in the earth or the ground, it's common to find exposure among miners, quarry or gravel pits, but also in construction. You can see the picture in the top right where someone's cutting through concrete that contains silica. There's also sandblasting that occurs. And it is a particulate. So when we think about the hazard, it's a particulate hazard. And what we are most concerned with are the really small particles. And that's because they reach deep into the lungs. So they can cause problems throughout the respiratory tract particles, but the small ones get deeper into the lungs and they can cause bigger problems there. So we heard mention of Carex Canada from John. Carex Canada does estimate that in Ontario, there's about 150,000 workers who continue to have silica exposure at work, and that's over 400,000 if you think of all of the country. And it does lead to a variety of health effects, which I will talk about in a subsequent slide here. So The one that I'm going to talk about today is silicosis, but there are other things that we worry about for workers who have silica exposure. So silicosis is not a new disease. It was one of the earliest observed occupational diseases. There are records of this being noted by Hippocrates and by Ramazzini, noting disease in stonecutters. Historically, in the 20th century, we had targeted medical surveillance in the province of Ontario that was the aim was to detect silicosis among underground miners here in the province. Silicosis does typically arise after many decades or years of low level or chronic exposure. And you can have different kinds of silicosis. I'm not a clinician, but there is sort of simple silicosis that can be largely asymptomatic. You are hearing more these days about progressive massive fibrosis, or PMF, which is sort of very accelerated. And we can have acute silicosis that occurs over a much shorter time scale than the traditional sort of chronic silicosis that we are used to seeing in these miners in the past. Silica exposure in workplaces has also been linked to lung cancer as part of the occupational burden of cancer study from the Occupational Cancer Center, where I used to be located. It was estimated that about 570 cases of lung cancer each year due or attributable to silica exposure at work. And if we look just at Ontario, that's about 200 cases of lung cancer arising from exposure at work. And then beyond cancer, like most dusts, silica exposure can lead to chronic obstructive pulmonary disease, or COPD. In areas around the world where tuberculosis is more common, you also can see silicotuberculosis arising. And there is a suggestion that there's an association between silica exposure and a series of other diseases like rheumatoid arthritis or systemic sclerosis or some types of lupus. And this has been noted in the literature for quite some time, but never fully explored, I don't think, and not a conclusive relationship, but it's certainly something that's getting some discussion these days. So I'm going to focus a bit now on artificial stone, because this is, I'm just going to peek forward, yeah, because in the past, we definitely saw silica exposure in miners and construction workers, and that, I'm just peeking at my slides for a second. Yeah, so that was unfortunately quite common in some groups of workers, and that was leading to chronic silicosis in those folks. But what we have seen in more recent years is a reemergence. I'm going to slide forward for a second here. What we have seen is a reemergence of silicosis in some new places. So the first place I heard about it was in people in Turkey who were sandblasting denim jeans. So folks will maybe not remember about 10 years or so that aged jeans or artificially aged jeans were quite fashionable, and a lot of those were being generated through sandblasting of the denim material in fairly confined spaces with poor ventilation. And so that was a group where we started to see some acute silicosis among those workers. It's also been noted in jewelry polishers or dental supply manufacturing. And the one that's gotten a lot of attention more recently is artificial stone workers. And so this artificial or engineered stone is often being used for countertop materials. It's very popular. It has lower maintenance than some of the natural stone products. It's more durable and less porous, and it can be made thinner and lighter than some of the natural stone. So it's desirable. It is manufactured, so the quality control aspects of the aesthetics can be less variable than a natural product. And so It has become common. As you'll see in that first bullet, the concerning part is that it's over 90% crystalline silica by weight, and it is often stuck together using resin. And that's gotten a little bit of attention. Resin itself can be quite harmful, but the silica is what I'm going to talk about. So 90% silica by weight. Just for comparison, when we look at some of the natural stones, that's much, much higher, 30% in granite, 3% in marble. I've pulled the mining numbers just for comparison because certainly in Ontario, we have been concerned about silicosis in miners, and there's quite variability in the silica content of ore around Ontario, but it's much lower than these artificial stone products that workers are both manufacturing. So in the bottom right-hand corner, you can see a facility where they're mass producing these slabs. So there is manufacturing that's occurring, and there's concern in the manufacturing sector, but also in the construction sector, which is where the installers would fall into. So trades that are installing in residences or in businesses are also doing some cutting and maybe some final shaping in that installation process that's going to be done in place. And so the ability to institute exposure controls in that setting can be a bit challenging. So, but all to say, there definitely are exposure controls that can be used. And these images come from Dr. Afanasieva, who works with the Ministry of Labor, Immigration, Training and Skills Development here in Ontario, and was part of a presentation that Dr. Tarlow and Dr. Lau and I did for a medical round audience. But you can use, engineering approaches like CNC controls to remove the worker, to put the worker at a distance. So they're operating the machinery rather than being very close to the cutting that's happening. You can use wet methods. You can see in the top there, there's a combination, the top picture, a combination of wet methods and local exhaust ventilation and personal protective equipment in that image from NIOSH in the US, just showing how you can layer controls to really reduce exposure levels. Administratively, things like job rotation and having folks moving from high exposure roles to low exposure roles over the day or the week could potentially be a benefit. And then the use of protective equipment, sort of working our way down the hierarchy of controls, and just showing you here a P100 respirator. So it does lead to the question of, there's a lot of discussion about artificial stone and silicosis around the world. What is happening in Ontario? This is a question that has come through my inbox several times lately. What is happening here? I have reached out to colleagues in BC who have not yet really seen any cases that they have identified, but here in Ontario, certainly there are cases, not a wave, but physicians are seeing cases of silicosis, some folks where they are symptomatic and they're seen because they're struggling, but others who are asymptomatic and have silicosis detected just during other investigations that are happening clinically. Although the cases that I'm aware of have tended to have durations of exposure between 20 and 30 years, there are some with less than 10 years, suggesting a more accelerated onset of silicosis. But among the cases I do know of, they are very severe diseases leading to transplantation in some cases, and some have put in WSIB claims, and these have been accepted, and they have been compensated for this. And you'll see I am being intentionally a bit vague here because I am not a clinician and I don't have permission to discuss the individual cases in detail, but I did want to be clear that clinical colleagues are seeing cases here in Ontario, and they are quite severe. And that's not unique. As I've sort of alluded to, these cases have been reported around the world really over the last 10 or 15 years. So some of the earliest cases from Spain in construction workers from Israel, which is actually where the head office of one of the large brands of engineered stone countertops was based, as well as in the US, a bit closer to home. The Cecile Rose and her team published in Mortality and Morbidity Weekly on 18 cases from 4 states, and also a separate paper from the US looking at in one facility where they investigated 43 workers, they found a rate of 12% of those individuals had silicosis on examination, so quite high. And that's very similar in Australia, where they've done quite a bit of work to really try and assess the magnitude of this problem. And so Dr. Hoy has set up this Victoria is a state in Australia, the Victorian Stonemason Health Assessment and Program. And they've enrolled workers working in this sector, over 1,000, so 1,400 folks at the time of this publication. And of those that registered with the program, they found silicosis in about 10% of those individuals. So that's a little bit consistent with that earlier American paper. If they look only at those that completed all of the evaluations, that number does come up a bit higher, a finding of about 1 in 3, which is quite a startling number. I wrote to consider the potential bias here on my slide, because certainly the denominator in this work is the people who have elected to participate in the program. And I just want to be clear about that. It's not the whole working population. So it's only among those individuals who have chosen to participate. And you can imagine that there might be a bit of a bias to folks who are having problems, who are concerned about their health, enrolling, and the folks who are not having any problems at all, choosing not to. So what do I know that's happening in Ontario? So, we have these cases that are showing up in the clinical setting. There are WSIB claims for silicosis from these workers. We don't have those exact numbers just because of the way the claims data is reported publicly. Back in 2020, right at the start of COVID, the Ministry of Labor, Immigration Training and Skills Development did put out a hazard alert, which remains on their website, about silica exposure during the countertop manufacturing and installing. There have been, and I can kind of see the comments, so I'll try and address them at the end. There have been workplace inspections by the ministry. I don't have a fulsome review of this, but there is some data that's available through the open data portal that seems to suggest that there's definitely active work in this space on the enforcement side, and work that the group that I mentioned at the beginning, we decided to look at the administrative health data and look at the population level, because these clinical colleagues are seeing the cases, and we wondered whether we could see any change in the trends at the population level. And so that's what I'll just touch on for you next, if I can get my slides. There we go. So we used information from the Ontario Health Insurance Plan data that's housed at the Institute for Clinical and Evaluative Sciences. And this allowed us to look at the whole population of Ontario and look at the rate of silicosis over time. And so we looked from the mid-90s up until the end of 2019. And on the left-hand side are the trends for silicosis in men and women. So the men are the diamonds, which is a slightly higher rate over time. And the women are the circles, which is a lower and flatter trend over the course of that period. And we did do, for comparison, we looked at asbestosis as well, which is what's shown on the right-hand side, just to see whether the trends were consistent with another respiratory disease that is largely occupational, and though caused by a different exposure, asbestos in this case. And we see a similar decreasing trend, although the rates for asbestosis are a bit higher. The axes on the Y are the same, so the position of the lines is comparable in this presentation. So for silicosis on the left, the rates are low, and we see that they've decreased over time, and we don't see an uptick at the population level. And again, just to comment on who's in this study, as I did for the Hoy work earlier, this is the whole population. So this is not just exposed workers in Ontario, this is all of Ontario. And so we're not seeing a trend at that level, which is perhaps not surprising. I did want to say that this is consistent with what's being seen for silicosis in other population level work around around the globe. This is an American study here shown on the right for Medicare beneficiaries, but showing over this a period overlapping fairly similar trends, although the rates are a bit lower here in Ontario. I thought it might be of interest to folks to just see results from this work by geographic region. So this breaks it down by age and geography, but just to say that over all of the age groups over 50, the rates of silicosis are higher in the north in Ontario, where mining is more common and where historical exposure, which would probably be more likely to be associated with chronic silicosis, would be higher among the population. So some of these population trends are discernible, but certainly a steady and consistent decrease at the population level. So I think the conclusions that I wanted to share and that I think come out of the little bit of work that we've done, even though there's a big interest here, is that we haven't really seen the full impact of the artificial stone work here in Ontario. We know it's happening, but we're likely to continue to see cases and to see an increase in the impact. I do think that we need to better understand this industry. It's not one that has been really easy to find connections into, and they don't seem to be, as a sector, really strongly connected into the health and safety system that we have. So I think there's still work to be done there. I saw a comment flash up about the workers around in other areas that say California, that these workers are often new immigrants or may not even be working legally. And certainly that's something that we can't currently assess here in Ontario, but certainly could be an issue here as well. From a hygiene perspective, there are prevention measures available. We do have regulatory tools in Ontario. Silica is a designated substance, and we have an occupational exposure limit in our regulation. So we have the ability to regulate, and we have prevention measures that could be implemented. But from a tracking perspective, we really do need ongoing surveillance, and that can't just be at the population level. Those cases are important to be tracking. So thinking about individuals and targeting those high-risk individuals certainly will be important for monitoring this. And then just ensuring that continuing that prevention pathway, we want to reduce exposure as primary prevention, track disease and have early detection as secondary prevention, and ensuring that we get an accurate diagnosis and that compensation claims are submitted, and that these workers who are unfortunately affected are supported in their health care and their quality of life. So that's all I have from me, but I know there's questions, so maybe I will stop sharing, Krista, and then I can see the chat and people can unmute. Is that right? Yeah.
That sounds perfect. Why don't I read the question out to you?
Sure.
Well, actually, you kind of addressed it a second ago. So is underreporting in Canada a problem? So.
Yeah, I think with occupational disease, we're always concerned about underreporting, even if the disease, might be recognized, or it could be not necessarily misdiagnosed, but it could be caught as a pulmonary fibrosis, but the causal link with silica not recognized. There certainly could be underreporting in terms of the claims and whether people are submitting claims or not as well. So yeah, I think it's almost certainly a problem in terms of the worker community. I just can't say. I don't think, I personally don't have a good sense of whether the workers in this sector are likely to be new immigrants or to be here through, say, temporary foreign worker programs. It's unclear to me at this point in time.
I'll read a question from Bajosi, who says, great that there are occupational limits. Is there a policy for surveillance, and what does the implementation currently look like?
Yeah, I think there are people on this call who might be better positioned than I am, but certainly under the designated substance regulation, which is OREG 490, if I'm not mistaken, there certainly is a requirement for medical surveillance among workers with exposure. But I don't know that that is evaluated particularly well. So, I know that many, many years ago now with isocyanates in the 90s, there was a lot of work done by Dr. Charlo, who was involved in this, and Gary and Dr. Liss, looking at medical surveillance in body shops around isocyanates. And certainly they found that adoption or adherence with that was quite low. I suspect it's similar here, that folks are not that are not fulfilling the requirements under that regulation. Now, whether that's because they don't know or they do know and they're choosing not to do it is hard to say. Can I comment on the comment further up about the physician?
Absolutely.
Yeah, so that's true. So there's the question in the chat from Lawrence is that, physicians in Ontario get a preferable rate for billing their visits as pulmonary fibrosis instead of silicosis, and that's true. So those data I showed you are from the paper that Krista has linked to, and it certainly was something that we found along the way. So what that means is that when you see a physician, they or their office or their hospital creates a billing record, and there's a diagnosis code attached to that billing record. And the pulmonary fibrosis billing code allows the physician to, I forget the word, but it's like an additional fee that they can collect for complex cases if they use the pulmonary fibrosis code. And if you use the silicosis code, you cannot additionally claim expenses for the complex cases. So it was something we couldn't really quantify. We couldn't quantify as well as we would have liked, but it's definitely a potential problem, and it would have affected the asbestosis as well as the silicosis, because the asbestosis was also not part of that complex code.
Anyone else with questions? You're welcome to unmute or put it in the chat. Okay, so that's a great question. Sarah McDonald asked, what is pulmonary fibrosis?
Oh gosh, yeah. So I saw some physicians on here. Yeah,
I know the nervousness of answering a question with physicians.
Well, yeah. So it isn't so the pulmonary fibrosis, so it's I'm gonna mess this up, I think, but so they're both fibrotic lung diseases, but silicosis is caused by silicosis and asbestosis is caused by asbestos. And pulmonary fibrosis generally could be many, many different things. Idiopathic pulmonary fibrosis, which sometimes gets tossed around in the occupational world, is a pulmonary fibrosis that we don't know what causes it. So my understanding is that from a clinical perspective, they're quite similar, but the cause is different. But the terminology is important, especially to think about the idiopathic nature. So sometimes people look at the idiopathic cases because they think those are likely to be occupational. And so they look at idiopathic pulmonary fibrosis. We did not do that in our work. We looked at all of the pulmonary fibroses billing information. And so it was a real mixture of things. It was certainly not likely to be largely occupational in what we did. So we did take a slightly different approach. Did that help, Sarah?
Thanks, Victoria. Yes, I am wondering if the average physician can make the different diagnoses and then point to an occupational exposure. Do they have to, you know, maybe it requires an extra step of going to a specialist, but I am wondering like what happens at that first visit. Did they just say, pulmonary fibrosis because I get an extra bill for it? Or what, how much do they know? And I'm like, physicians have to know a lot. I'm not disparaging their field or anything, but I just want to know how much can they actually diagnose right away.
Yeah, I think it's a long process, and I think that comment about it's not something that you know, in some cases it can be done through the general practitioner or the family doc, but often it involves specialists and it involves detailed occupational history taking to understand the exposures that someone might have had. So I think it is complicated, and I think it's there's a lot of work ongoing in the occupational medicine community to raise awareness among their colleagues of the importance of taking an occupational history, and that applies not just to questions of pulmonary fibrosis, but really all the occupational diseases. Um, and like work through questionnaires and things like that. So I think it's something, it does require a thorough occupational history, and it requires investigating what exposures people have had in order to make that diagnosis.
Okay, I think that's likely it for questions. We're going to take a 5-minute break now for those who need to stand up and stretch. And when we come back, we'll finish off with the last session.
Sorry, Krista, I lost my internet.
No need to
Can you hear me?
apologize. Yes, we can hear you now.
Oh, perfect. Because your intro is up right after the break, right, Krista?
Yes.
Okay, because I was like, I didn't want to cut her off with questions or anything. And oh, sorry, actually, this is still live, right?
Yes.
Okay. I'll do your intro right after the break.
Okay, thank you.
Thanks. Okay, welcome back, everyone. Are we ready to get started? Okay, shall I get started with your introduction, Krista?
Yeah.
Yes, okay,
Yeah.
wonderful. Oh, this is Krista. Krista Thompson has a Master's of Health Science in Occupational and Environmental Health. She's a registered occupational health and occupational hygienist and Canadian registered safety professional. Krista has experience in a range of sectors, including pharmaceutical, oil and gas, manufacturing, healthcare, and consulting. Krista has been with OHCOW since 2018. She's the lead of the TLV submissions group, chair of the COVID and infectious disease reference team, and she's also assisting with the silica control tool launch that we will be focusing on in next week, October. Over to you, Krista.
Thank you so much. So I'm going to talk about evidence for new occupational exposure limits. I will be talking specifically on the TLV process, and I'm going to be using some acronyms. I will define them all. So I'm going to go through what are occupational exposure limits, or OELs, what are ACGH TLVs, what is the submission process for TLVs, and just an overview of OCCOW's recent submissions. So what is an occupational exposure limit, also called an OEL? This is the level of exposure to which most workers can be exposed without adverse health effects. So there's a few things going on here when we talk about most workers. Within the group of workers, you take a population of workers, there's going to be a healthy worker effect or phenomenon or bias, known as all those things. Essentially, out of the population, people have to be healthy enough to work. So we're excluding all the children, we're excluding the older retirees, and we're excluding those who are unable to work for many reasons. So healthy workers are already a healthier than average population subset. We also have sensitive individuals or individual sensitivities to consider. There's individual social history, where you grew up. If you grew up in a home that smoked, if you smoke, there's your individual risks and your genetic or familial predispositions. So while most workers can be exposed to a certain level of a chemical or other agent without adverse effect, we know there is going to be a small population that could still have adverse health effects when exposed to the occupational exposure limit. Occupational exposure limits are usually based on an 8-hour day or a 40-hour work week. We're assuming that outside of those 8 hours, you're going to a zero exposure state or a very low exposure state. So when you have someone working a 12-hour day, we're going to have to adjust it. And when you have someone who works in an area with environmental exposures, for instance, now you don't have time away with zero exposure. So that's going to be a little different too. So what types of OELs are there? They're not all the same. There's different types. We have the legislated occupational exposure limits. Most in Ontario are considered Ontario workers. They would apply under Regulation 833 and Ontario Regulation 49009, which is a designated substance regulation. Mining workplaces would have Regulation 854 to follow as well. Now, there are federal workplaces in Ontario. They apply under, they would have to follow the Canada Labour Code Part 2. We also have governmental agencies that make occupational exposure limits that are not legislated limits. The most common one that I've seen cited are the NIOSH RELs. NIOSH is the National Institute for Occupational Safety and Health, and REL means recommended exposure limit. We also have scientific group limits, and that's what we're going to be talking about a little bit more today. The ACGIH TLVs, that's the American Conference of Governmental Industrial Hygienists, threshold limit values. And then there's industry limits. So manufacturers may develop their own internal limits, particularly if they're using a chemical that doesn't have an OEL in one of these categories. Industry associations may develop industry limits that they recommend everyone within their industry follow. And pharmaceutical companies typically have their own exposure limits for pharmaceutical agents or control bands. And the reason they have that a lot is most pharmaceutical agents don't have occupational exposure limits. So pharmaceutical companies will develop their own, which they are usually basing on animal testing data. So I'm going to talk about the Ontario occupational exposure limits and give you some, for some of the hygienists on the call, this is going to be a refresher. I think for some other people watching, this might be new information. Hopefully most of you are in the middle and I'm not boring you too much. For the hygienists, this is our meat and potatoes. This is where we get excited. So we have the time weighted average limit, TWA. Yes, the word limit's in there, but there's no L in the acronym. This is the time-weighted average airborne concentration that you can be exposed to in a work day or a work week. We also have short-term exposure limits, STELs. This is the maximum airborne concentration you can be exposed to in a 15-minute period. You can have no more than 4 STELs per 8-hour shift. You have to have at least an hour between each STEL, and your average still has to be below the TWA. And then we have the ceiling limit, sometimes just called C. This is the maximum airborne concentration to which a worker may be exposed at any time, and that shift average must still be below the time-weighted average limit. So that's Ontario, but what happens if you have a time-weighted average limit, but no STEL and no ceiling? Then the excursion limits apply. So in Ontario, the excursion limits are called short-term exceedances or excursions above the time-weighted average limit. There's 2 excursion limits, so no exposure can exceed 3 times the time-weighted average limit for any period of 30 minutes, and no exposure can exceed 5 times the time-weighted average limit at any time. As well, that shift average exposure must still be below the time-weighted average limit. So when I see sometimes situations where monitoring has been done and only looked at the time-weighted average limit, and the report says there was no STEL, there was no ceiling, I feel like there are cases where the excursion limits could have been looked at, but there isn't a great awareness always of them. So I always like to take the chance to highlight them because they do provide additional protection and guidance for Ontario workers. So where do these occupational exposure limits come from? Well, most, not all, but most Ontario time-weighted average limits and STELs and ceilings, I should have said that as well, are adopted from the ACGIH TLV booklet published in 2017. And you can find a complete list at this link here. I realize that's a little bit tricky on the screen, so I will put the link in the chat when the presentation is done. The ACGIH publishes an updated TLV and BEI booklet every year, so this is a little out of date. We're getting 6 years out of date now, so it is a little out of date, and there are some limits that have changed in the meantime. So one of them is silica, has now been recommended to be lower by the ACGIH, and Ontario has not yet adopted because we're still using the 2017. Okay, so I've been talking a little bit about ACGIH without really explaining who they are. I said their acronym, American Conference of Governmental Industrial Hygienists. They were actually established in 1938 as the National Conference of Governmental Industrial Hygienists, and they currently have 9 committees. They have an Agricultural Safety and Health Committee, Air Sampling Instruments Committee, Bioaerosols Committee, a Biological Exposure Indices or BEI Committee, an Industrial Ventilation Committee, an International Committee, a Small Business Committee, a Threshold Limit Values for Chemical Substances Committee, and a Threshold Limit Values for Physical Agents Committee. So being fully transparent here, I'm a member of ACGIH. I'm not on any committees. So I have membership in the organization. I'm not involved in any of these though. So looking at that brief history, in 1941, the Threshold Limits Subcommittee was created to start looking at airborne maximum concentrations for chemicals. In 1944, the Threshold Limits Committee became an independent committee. And in 1946, they got to work quite quickly because they started from scratch, and now they have 150 maximum allowable concentrations published. In 1948, they renamed MAC to be threshold limit value, TLV. And starting in 1955, they started to publish documentation for each TLV, so people could look up where did this TLV come from. Before it was just a number, now there's actual documentation. And in 1981, they started publishing a list of substances and issues under study. So you could look up, what are they thinking about? So types of TLVs. Often when a TLV is said just TLV without context, it is often referring to the TLV TWA, which stands for time weighted average. Now I'm just going to point out TWA in the Ontario legislation means time weighted average limit. TWA from ACGH just means time weighted average, or your average exposure based on 8 hours a day or 40 hours in a week, of which it is believed nearly all workers may be repeatedly exposed day after day for a working lifetime without adverse effect. Note that that says nearly all workers. That goes back to what I talked about before, that there will be some people who have adverse health effect depending on their unique circumstances. ACGH says that anyone using TLVs must consult the latest documentation for that substance or agents to understand the basis of the TLV. There's also a TLV STEL, short-term exposure limit. This is an average for a 15-minute exposure. You can have a TLV STEL a maximum of 4 times a day with a minimum of 1 hour between those exposure occurrences. And the shift average must still be below the TLV TWA. And then there's the TLV-C or ceiling, and that's the exposure limit that should never be exceeded, and the average must still be below the TLV-TWA. STEL and ceiling are nearly identical definitions to what's used in the legislation for a STEL and a ceiling level in Ontario in terms of how they're defined. The actual values are not always identical because, again, like I said, Ontario is using the 2017 TLV booklet, and the 2023 has been published with some changes. ACGH also has an allowance for transient increases above the TLV TWA when there is a TLV TWA, but no TLV STEL. In this case, the 15-minute exposure level, exposure may exceed 3 times the TLV TWA. Very similar to the STEL exposure, no more than 15 minutes at a time, no more than 4 times per workday, with at least an hour apart. And exposure levels must never exceed 5 times the TLV TWA when measured as a 15-minute time-weighted average. So in this case, it looks like they're attempting to do a ceiling, but giving you a 15-minute time period to measure it. I will be honest, I find it very confusing that there's a TLV TWA exceedance allowed 3 times the limit for 15 minutes, and then there's an exceedance for 5 times for 15 minutes. What I think they're trying to do, and this is my opinion, and it doesn't reflect anybody else's opinion, I think they're trying to allow for time measurement for a ceiling sample. Oh, did not mean to go ahead too. So are TLVs consensus standards? Well, consensus standard is defined as recommendations or operating practices that are created by a group of experts that do not by themselves have the ability to be enforced unless it's adopted by a regulatory body. I had professors when I did my master's who said that ACGH is a consensus organization and TLVs are a consensus group. And you can pull a bunch of occupational hygienists and find some saying they are consensus standards and some saying they are not. It is actually something I have seen debated quite a bit on LinkedIn. So let's see what ACGH says. That's what matters. They say TLVs are not regulatory or consensus standards and are an expression of scientific opinion. So they're guidelines set based on the health evidence reviewed by the committee. So what type of OEL are they? Well, they're not perfectly evidence-based guidelines. And the reason I say that is because of the process of reviewing, which I'm going to go through in a minute, they aren't always up to date on the evidence. Some really great evidence come out showing an exposure should be changed, an exposure limit should be changed, and it can take a few years before it gets to the ACGH committee. But TLVs are health-based OELs. They are attempting to measure the level at which those health effects actually occur. Okay, so I'm going to go through, this is the process. Don't worry, I'm going to go through it step by step because this is a lot going on one slide. This is the process you can find on the ACGH website showing how a TLV is developed. So beginning of the development process, stakeholders and members of the public can make submission. Proposing substances or agents go on the understudy list. So anybody can call up ACGH and say, you don't have a TLV for metalworking fluid. Here's why I think you should have one. And the committee will consider it. So they're going, and there's 3 committees that could be considering it. There's the TLV for chemicals committee, the TLV for physical agents committee, like noise or radiation, and the BEI committee for biological exposure indices. So that's looking at biological monitoring, usually urine and blood. So what the committee looks at this point to see if something should go on that understudy list. That list that means we're going to look at it. They look at the prevalence of the substance or agent being used in the workplace, the way the substance or agent is used, the number of workers exposed, the availability of scientific data for this chemical. So is there a lot of studies or is there just 1 or 2 looking at it? The existence or absence of a TLV at this point in time. So if there's a current TLV, how old is that TLV? If it was published just last year, it's probably pretty current. If it was published 20 years ago, it may be worth looking at the updated evidence. And then they look at input and from the public and other stakeholders. Okay. So, as I said, the committees are the TLV for Chemical Agents Committee, the TLV for Physical Agents Committee, or the Biological Exposure Indices Committee. So once they've looked at whatever chemical or agent has been proposed to them, they place it on the understudy list, and that's when it actually goes on their website. If you want to find it, you can actually go to Google. I think that's the easiest because it's a very, very long website, and you can just Google ACGIH understudy list, and it will pop up as one of the top search options you find there. I don't believe it's the top one, but you will find it. You can see what are they looking at? What do they think needs either a revised or a new TLV? I'm having issues with there we go. I'm just a little delayed there monitoring. So the understudy list is like a beacon to the occupational hygienists and anyone else in the public to say, hey, I am interested in your feedback about this chemical or physical agent. Anyone can make a submission for any TLV or BEI. You email science@acgih.org. They will send you the information you need. They do have a format that it has to be submitted in. They do have things they look for. When you do your submission, economic and technical feasibility should not be considered in submissions. So if you have an agent that you feel has the evidence for 5 micrograms per cubic meter, and current technology can only measure at 10 micrograms per cubic meter, they don't care about what's technically feasible. They want to know what's health-based. And if what's health-based is 5 micrograms per cubic meter, you need to demonstrate that. Their logic is the technology will catch up to the health-based monitoring. So once this understudy list is published, the next step is 1 or more committee members prepare a draft documentation with a proposed TLV in it. The draft documentation, it's a critical evaluation of the scientific literature. They're not going to necessarily review all the literature. They're going to review all the literature that was submitted to them, but they're going to focus on, yes, the PowerPoint slides are available, will be made available for my slides. I can't speak to the other presenters. An emphasis on studies and papers that address minimal or no adverse health effects levels in animals or workers or other humans in other types of studies. I will say that when I was doing a submission, I found some interesting studies from the 1960s and 1970s where students in college in the States were paid to be given chemicals and document their health effects and how long it took to reverse. It was interesting because they were essentially getting these students to be quite exposed, and that passed ethics at the time. So you can find just average people, older literature, hopefully, of average, well, it's usually college students being exposed. And then they want to look at studies that address reversibility of effects, because they do care about the reversibility. And the draft documentation, as I mentioned before, includes the proposed TLV. What threshold limit value will it be there? And the committee then reviews the draft documentation. So 1 or 2 members prepare it, and then the whole committee reviews it. It is not available to the public at this point. And if the committee accepts the draft documentation, they give it to the ACGIH Board of Directors. And if the ACGIH Board of Directors ratifies it, then the proposed TLV is published. It's published as either a notice of intended change, so that would be changing an existing TLV, or a notice of intent to establish, so a new TLV. Once that agent is published as on the NIC or NIE list, then the draft TLV documentation is made available to ACGIH members as well. Non-members, their website says can get it through ACGIH customer service. I have not had to try before, as I am a member, but they do say that on their website. And all parties may comment, ACGIH members, scientific committees, on any member of the public can comment on any substance or agents on these lists. The ACGIH does have criteria on their website. As I mentioned, they have specific formats they want used. They say that the most useful submissions address the points in the draft documentation. And based on the submissions they receive, they basically have 3 ways they can go with this. They can make changes or updates to the draft documentation. So they can keep changing that draft documentation as many times as they need till they feel they've got it right. And that could include changing the proposed TLV. They can recommend the TLV be adopted. Hey, everything looks good, looks great, we're going to go ahead. And they can withdraw the TLV from further consideration. So no, we're not going to do this. If the ACGIH Board of Directors agrees with the committee recommendation that the TLV be adopted, then it is adopted and added to the next TLV booklet. Remember, they publish every year. So I just went through this flow chart in a nutshell. I'm sure there's a lot more to each step for everyone, but that is it in a nutshell. So chemicals that OCCOW has made submissions for include aluminum, diesel exhaust, lead, nickel and nickel compounds excluding nickel carbonyl, welding fumes, 3 anesthetic gases, desflurane and fluorane and sevoflurane, soldered solvent, and metalworking fluids. So 3 that I wanted to highlight, I've kind of picked one from each category. Metalworking fluid is not currently under study. It is not on an NIC list or an NIE list. There's no TLV for metalworking fluid. So we made a submission recommending it be placed on the understudy list, and we recommended the limit be set at 0.1 milligrams per cubic meter. Diesel exhaust, which is actually a complex mixture, we recommended it be measured as elemental carbon. It was on the understudy list, so we recommended it be moved to the notice of intent to establish list and be set at 10 micrograms per cubic meter. Now I'll say this, we actually based this on technical feasibility. We were unaware that they did not care about technical feasibility at the time. And we do say right in it that if it was based on health effects alone, it would be 5 micrograms per cubic meter, which is actually the same figure that OCRC came up with for their recommended exposure limit as well, for non-mining workplaces, that is. And lead, we recommended it be removed from the understudy list and added to the NIC list, notice of intended changes, and recommended it be set at 0.004 milligrams per cubic meter, or 4 micrograms per cubic meter. To this day, it does remain in the TLV booklet at 0.05 milligrams per cubic meter. So we were recommending quite a reduction, and it has not yet. But I wanted to highlight that those are recommendations that OCCOW has made. So I will put the submissions in the chat so you can find them when I'm done speaking. We made one submission in May of 2022. One in March of 2023, and one in October, just earlier this month. So I'm going to ask if anyone has any questions. while I'm sharing, I only see the chat when a question comes up briefly, and I can't see the full thing.
So I can read them for you if you like.
That would be great, Sarah. Thank you.
Yeah, it appears we currently only have the one question, and the question is asking if the PowerPoint slides will be made available to attendees.
Mine will. I can't speak for Dr. Arrandale or John. I hope they will agree to that, but I know sometimes there are reasons some things can't be.
I have another question. Krista?
Yes.
Sorry, I'll let Victoria respond first. Not sure if she's on. I'm sure she, yeah, I guess you can ask her after. Just wondering about nanoparticles, and maybe this is out there because OELs don't cover that kind of thing, but I looked at the understudy list and I have no way of knowing if any of those things are nanoparticles or even what that is, but John's survey results piqued my interest.
Yes. So right now, for the most part, oh, John says his slides will be available. For the most part, they're referring to not at the nanoparticle scale. So aluminum, for instance, is not referring to aluminum nanoparticles. The concern with nanoparticles, speaking off the top of my head and thinking back, because I haven't looked at nanoparticles in a little while, they are so much smaller than what we would normally be exposed to. The concern is that when you inhale it, it can either get deeper in the lungs than it would normally get, or perhaps cross the gas exchange region in the alveoli and get into the bloodstream. I know that's been a hypothetical concern. I'm not sure if the evidence bears out that hypothesis. So that would change things as well. I have not seen a TLV. I don't have the book memorized, but I have not seen a TLV for a nanoparticle. If anyone has, please jump in and let me know. I have seen, I think it was a NIOSH REL for nanoparticles. I think it was carbon nanotubes. But that was about a decade ago that I looked at that, and I'm sure the literature has changed quite a bit in the last decade. I know it has.
Yeah, and I understand way more nanoparticles are coming into our environment. So they're not one thing, there are many different things that we have to track and become aware of over time.
That's right.
Thank you so much. Also, thanks to OHCOW for making those submissions.
Oh, we had,
on behalf of workers in Ontario.
we I think had a lot of fun doing it. It was a learning process. I think we got much more efficient as we went along. So we definitely learned a lot at each stage and had a lot of fun digging into the research. Again, not everyone has fun digging into the research. We do. We just love dealing into it. Oh, is that SI being silica? Oh, Martin says titanium oxide ACGH 2022. Yes. So I was talking about silica. Silica, Ontario's limit is, Megan or Shirley, if you're there and I get this wrong, please let me know. 0.1 milligrams per cubic meter based on the 2017 TLV. That's Ontario's limit. ACGH has changed the limit and it is now 0.025 milligrams per cubic meter. And so, yes, that is something that we have encouraged for adoption. And hopefully that is something that will in the future be adopted. Silica in 2006. Okay, I'm glad I got Martin here. So for whatever reason, Martin is letting me know the ACGH adopted that lower limit in 2006 and Ontario has not. So if that's the case, it's been a long time. Yes, I think you're right, Trevor. Formaldehyde can use an update. It's another one that I have seen. I think it's quite a bit lower for formaldehyde. So there's a few there. So I didn't realize how quickly the comments pop up when you're chatting and then sharing your screen and then disappear. So if I miss anyone's questions, please feel free to ask it again, unmute yourself or put it right in the chat again if you'd rather not speak. I know one thing, I'll just stop in case anyone is typing with silica, is that there is an upcoming push for silica awareness. Dr. Arrandale alluded to it, talking about her research has been part of that push. OCCOW has our silica control tool that we're going to talk about and launch next week on November 3rd. So there is a greater awareness of the hazards of silica and silica related diseases. So hopefully with that greater awareness there does become an impetus to lower the TLV. Yeah, that's definitely on my checklist of things I would like to see happen sooner rather than later. I know that with these updates, the ministry will have challenge. They have a shortage of resources right now. I mean, we all do. So they have a challenge dealing with and addressing occupational diseases, and they have different limitations in what they can do with the resources they do have. So hopefully with OHCOW's resources and encouragement, we can help provide that evidence to encourage those decisions. So if anyone wishes to get a hold of OHCOW, John put up his personal email earlier. You can also email ask@ochcow.on.ca. And we have our toll-free number there. You can, if you want to write this down furiously, you can. You can also just find it by Googling OHCOW, and you'll find it come up. Before I stop sharing my slides, I wanted to mention that this was the first October session. We have a session coming up November 3rd. That's our silica control tool, which I just alluded to, launch, and our Ontario Occupational Health and Safety System focus on occupational illness prevention. On November 10th, we have the Occupational Disease Landscape Review, Highlights and Solutions. On November 17th, we have Exposures and Diseases, Making the Link. And our final one, October for this year, is November 24th, Airborne Hazard Management Programs, Reducing Exposures in Mining. Okay, I'm going to read out the plug that was just put in here. A plug related to occupational history taking. I'm reading this out loud because I know there are people watching on Facebook Live. I don't want them to miss this. A collaborative group with Dr. Arrandale on the team is piloting an occupational history recording tool for Ontario Health to use with their patients. So there is the link there. I'll try reading it out loud. ecoem.iwh.on.ca/occupational-history-recording-tool. Free to all, test it, share us, tell us what you think. Yes, I believe that's what Dr. Adisesh is talking about, Sarah. John's put his email in the chat, so I'll read it out. joudyk@ochcow.on.ca. So I'm going to close this session out a couple minutes early. Thank you all so very much for your time. I did say I would put one thing in the chat. That was the link for the Ontario OELs, I believe I said I would do. So let me do that right now in case anyone wants it. Make sure I send it to everyone. It's a long link. It's essentially the Ontario limits. If you look up Ontario Regulation 833 table, it'll probably be, I think, the third thing that comes up in your search history if your search history is similar to mine. So thank you so very much. At the beginning, we had a link put in to complete your feedback. I'm going to plug that in the chat again. Please complete that link so we can get your feedback. We really do take the feedback seriously and value your time for doing it. I want to thank Dr. Arrandale and John for presenting today, and I would like to thank you all for being here, for your time, because I know that everyone has a lot going on these days. So the fact that you made time to be with us, we're very honored for that. So have a great rest of your day. Have a great weekend. And let's go change the occupational health and safety world.